Okay, massage therapy friends, I've been thinking this a long time and I'm finally going to say it. The way we chart is ruining our professional relationships. Especially if the chart format you use begins with that classic subjective objective division. It has the potential to confuse your clinical reasoning, degrade your therapeutic relationships, and rob you of the key value that you can offer the rest of the healthcare team. Theoretically, a chart note should be a quick way of taking down the most relevant details and then transmitting them across time and between providers so that a person receiving care can have the most informed and equipped healthcare team possible. And this is why many chart formats begin with subjective, what the patient tells you, and then objective, what the practitioner observes. However, when it comes to massage therapy, and really any other interactive healthcare profession, that subjective-objective split doesn't capture the most relevant info. And often, it forces us to contort our perceptions and misrepresent what we observe so that we can seem rigorous or believable to our other providers. But this is a trap, and I'll show you why. If we're being honest, there's actually 3 valid perspectives on what transpires during a medical visit. There is the patient subjective, there is the practitioner subjective, and there is the objective, which is that information that a third observer could confirm just happened. Quite often, we have been taught to portray our practitioner subjective data as if it were objective. For want of rigor or infallibility or something else, we have a habit of speaking as if our subjectivity is actually objective. And this confuses us to no end, and it has been going on for decades. I'll give you an example. When I published my first peer-reviewed paper in a medical journal, it was a case report of massage therapy sessions, and I wrote a sentence that was something like, "The practitioner observed hypertonicity in the anterior scalene muscle in the first through the 6th sessions, and on the 7th session, that hypertonicity normalized." Notice what I did there. I portrayed the tonicity of the scalenes as if some third observer could automatically find the same thing. But that's not true. I should have said, I went looking for the shape of a scalene, and I perceived it to be abnormally hypertoned. And then, when I checked again on the 7th session, it felt more normal to me. When I include the practitioner subjective, it doesn't actually make me less rigorous. It just owns the fallibility, the particularity of how I came to feel that scalene. I don't make the assumption that another provider could feel the exact same thing. And isn't that a better way to start a communication with another provider or with one of my patients? To admit the conditions that lead to my perceptions, which is my own hallucinations along with my palpatory skill, right? But so much crucial information actually falls into the practitioner subjective frame of mind. Think about it. Affective and autonomic responses. Are those really objective, or are you using your system to feel their system? Emotional valence. Do you ever find yourself working on a spot and it just touches off a sense of deep relevance for yourself and your patient? Isn't that worth noting, communicating? Where does it go in the SOAP chart? Who knows? Almost all of palpation is practitioner subjective. Does that make it worthless to communicate to your client, to your allied providers? Absolutely not. But you have to own your fallibility in this act. Because if you pretend that your palpatory observations could be observed by each next provider or by yourself across time, you may not be accurate. When I was training for oncology massage, the head of the wing told me, please tell your nurses, your other physicians, when you feel novel changes in the consistency of a tissue, there may be an unknown tumor there. The kinds of observations that emerge in an hour massage session are of crucial value sometimes to the rest of the healthcare team, if we are honest about the kind of information it is. So, when you think about charting, find a way to note the practitioner subjective and you will have better communication with your clients and with your allied providers. If you're interested in more on this perspective and how to go about doing this, I'm teaching a class coming up on medical communication for massage therapists. Check out the link below and have a great day.